Thanks, Sam, for the lovely introduction, and thanks everyone for coming today. It's very nice to speak to actual faces. I think it's the first time in 3 years, so it's really nice. Before I jump into what vicarious trauma is, I really want to give a huge shout out and acknowledgement to the pilot sites that we worked with over 3.5 years, Grace and I, and the frontline staff and the management in there, that they were really generous with their time and really candid with their experiences and what was happening and their ideas. And without that, we really wouldn't be here today with what we have to say. So it's really a dedication to them. So we've been researching vicarious trauma for 3.5 years now. And really, to kind of jump into this, I really need to explain what vicarious trauma is. Most of you have probably heard of it, but this is a quick 101. So the most applied and workable definition that we've come up with is vicarious trauma is a predictable response to work that involves repeated exposure to traumatic content. So there's kind of 4 key features, and it's, there's a lot in the literature and a lot of disagreement about what this actually means. But what we found when we actually talk to frontline staff is there's 4 key features. So the first is exposure to other people's trauma. And so what that might mean is case notes. So you might see written detail, written descriptions of kind of events that have happened of other people's trauma. It could be images or audio-visual content that you might see, kind of images of crime scenes in the course of your work. It could also be verbal disclosures. So a lot of people, you might think of a counselling setting, but it could also, we talk to admin workers who get phone calls from people, they're medical receptionists or admin in housing, and they get these desperate phone calls. And you wouldn't think they're admin workers, but there's lots of sources of exposure to traumatic content in a lot of roles. The second thing to know about vicarious trauma is it builds up over time. And so this backpack might be a bit of a weird icon, but it's actually a really good visual that if you imagine wearing a backpack and you're going into work, and every day, every time you hear a traumatic story or you're exposed to some kind of traumatic content, you pop a rock in your backpack, it's going to get heavy. And these people are hearing these things and seeing these things day in, day out, all day long. And it's really distressing content. And this backpack gets heavy and eventually something's got to give. The third thing we found is empathy is a precondition. So a lot of people that I interview, they say there's this real challenge with the work that they do, that they need empathy to be able to work with their clients and to engage and really do the work that they're doing with these really vulnerable populations. But it's the empathy that actually creates the risk for vicarious trauma. So it's a bit of a double-edged sword, but you can't remove that empathy at the same time. So it's something really important to acknowledge. And the last thing is it results in what we call a PTSD response. So there's no clinical diagnosis of vicarious trauma, but there is a lot of overlap with PTSD or post-traumatic stress disorder. And a lot of people describe this negative change in worldview, where they start to kind of see some part of the world or all the world quite negatively. So I remember interviewing one woman, and she talked about working with male sex offenders for a really long time. And that now when she was in the street, she would look at strangers and say, what are they capable of? And that's a really awful position to be in life, that you're out and, you're socializing and you're starting to think about what people are capable of. So that's what's really at the heart of vicarious trauma, those 4 features. When we talk about predictable, we're really looking at what the research is now saying, and the research is showing that kind of up to 50% of people in some professions are at risk of mental injury as a result of exposure to traumatic content. So that's quite a high rate, really, and we're finding it across a lot of occupations and a lot of roles that you wouldn't even think of. So it's really something to keep in mind, and that's really the problem that we worked to address in the public sector. So what did we do? In partnership with the Community and Public Sector Union, the Victorian branch, 2 government departments, we got together and we did this pilot program. And so this is kind of like a very high level program logic here. So we grabbed a project team, which importantly included subject matter experts. And then we got together 6 pilot sites that provided frontline services to very vulnerable populations in the community. And then we had a really great steering committee that worked together to really help the rollout of this project and oversee the project. Then we got to kind of the meat of it, which was this kind of piloting interventions that were based on the literature. We collected data on what was happening and what happened when we put these interventions in place, and we developed a toolkit. So this all kind of happened at the same time. It was pretty chaotic and intense, but great at the same time. And while we did this, it was we took an action research approach. So there was constant reviewing of what we were doing and kind of tweaking little things, what worked, what didn't work. And then we just kept going on these cycles. And through the 6 pilot sites, they did things at different times. So we really kind of got a lot of data and really were able to tweak what we were doing and try and come up with the best outcomes possible. So our main outputs from this project were the toolkit, which is available online now. And we've got a whole lot of data and a whole lot of findings and a whole lot of learnings, which we're sharing with you today. And Grace is working on that with the CPSU to build more at the moment. And then like our big blue sky outcome here was to prevent vicarious trauma. And we'll talk a bit about whether we were or weren't able to do that in a moment. But as I said, so we used action research. And the other unique thing about this project was it was really heavily embedded in lived experience. So we worked really closely with the people who were most impacted by it and asked them what they wanted done, what were the problems and what could be done and what they wanted done. And so that was, we really learned a lot from that. Like the literature is amazing and there's a lot out there in vicarious trauma, but really hearing from the people on the front line was a new perspective. And then we also use co-design methods. So a lot of the interventions that we piloted were designed with frontline staff, with management, with OH&S reps in each of these departments to really see what worked and what could be done and what's feasible. The other unique thing about the project was the way we looked at prevention of vicarious trauma. So we looked at prevention in these 3 ways. So we looked at eliminating unnecessary exposure. And so this we really did in consultation with client-facing staff to determine what preventable exposures there were. And it was really interesting in the beginning, we had a lot of people saying, you can't prevent it, it's inherent in our work. And then at the end, when we did follow-up data collection, people could start picking out and they'd say, I don't need to see this as part of my role. I don't need to hear this as a part of my role. So we even saw that shift there from the beginning to the end. The other thing we aimed to do was to reduce or control exposure. So we really looked at doing this through workload management so people could have lower levels of exposure, or job design. So one of our executive members really looked at kind of screening roles and seeing where the sources of exposure are, how severe that exposure is and how frequent that exposure is, and then designing jobs in accordance with that. So maybe they got a day off a week where they weren't getting exposure to traumatic content and they could kind of recover, or maybe they had more control over when they were exposed to trauma. So they just did it in the mornings and in the afternoon they didn't. So there was lots of different ways to kind of reduce the exposure. And the last thing we tried to do was mitigate. And that was when people, because we know it's inherent in the work, we can't remove the exposure, but what can we do? Because it's a normal human reaction to be impacted by distressing content. What can we actually do to kind of mitigate this impact and reduce the mental injury? And so we looked at doing this through trauma-informed supervision, reflective practice, and training on psychosocial hazards, among a lot of other things. And I just want to say that the focus of this, it's still important to have treatment approaches in place, like EAP and counselling and all those things are really important, but we really wanted to shift the focus to preventing that mental injury. And that's really a testament to the Workwell Mental Health Improvement Fund and the focus that took, because it made us continually, like we would get drawn down into this, we need to treat it, but it made us keep lifting it up and go, no, how can we prevent it and do that really hard work in that space? So what did we find? We found heaps of things, so much stuff, but this is kind of my quick 101 of what we found. So we found really high rates of exposure to distressing content. I think one person described it as a conveyor belt of distressing content. We also found that there's low levels of vicarious trauma knowledge in these workplaces. So for some people, when we came in, it was the first they'd heard about it, despite the amount of exposure they had. And then we found that those that did have knowledge, a lot of this knowledge was based on kind of cultural beliefs and hidden rules, which are quite common around mental health in our community. So, we don't talk about mental health because it's a personal problem. I'm not qualified to talk about those kinds of things. But if it's something you're exposed to day in, day out, and your colleagues all are, and no one's talking about it, it creates this kind of taboo, and maybe you're failing if you can't cope and those kinds of things. So we really saw that there was this kind of cultural idea of, no, we won't talk about it. And as a result of this, the risk to employees isn't commonly acknowledged. We did a policy audit of kind of 50 policies in a few departments, and there was hardly any vicarious trauma policies. I think there was 1 or 2, and they really didn't acknowledge the risk. They just kind of said, this is your problem, you need to deal with it. What we did find, though, was that prevention requires a tailored and multifaceted approach. So in a lot of our sites, we took an approach where we kind of tried to do the reduce, the eliminate, the mitigate, as well as what they already had, which was EAP and counselling and debriefing processes like that. And that really works. That is a really great approach. But often we found that the proactive approaches aren't commonly implemented, and we often had to keep redirecting conversation back to, hang on, how can we actually proactively prevent this? How can we look at this from a system approach? So these are kind of, I've probably touched on the barriers, and it sounds a bit negative, but we actually found that once you can address these things and then put in some really great interventions and strategies, and some of them are really, really simple, that prevention is possible. So it's just a matter of shifting the attention, shifting the cultural beliefs, and really it took a lot of courage for a lot of these sites to really open up and go, let's try this. And then it worked. So yeah, I'll hand over to Grace to talk more about that.
And I will try not to trip over. Firstly, I might start coughing because I did take a sip of my water and inhale it a bit. So I'd just like to apologize ahead of time. Please bear with me if I do that. Thank you. This, as Carmen said, there's a lot of people in front of me, and I have not spoken in front of this many people for possibly ever. So, and what I am going to spend the next couple of minutes talking about is taking what Carmen has said that we found basically. I'm also trying to juggle on this lectern. It's a bit of a mess on my side, not ISCRR. And talk about those impacts and the outcomes that happened. And first, I'll try not to break the laptop as I shuffle things. So as Carmen said, there were a lot of findings and data across all 6 pilot sites that indicated basically a lack of vicarious trauma knowledge and prevention. And the pilot period for the project was only a couple of years. So in terms of what we were looking at for the outcomes, and prior to jumping forward to my slides, I'm going to go back to Carmen's slides. If we look at this sort of project plan, as Carmen said, that outcome of preventing vicarious trauma in terms of the pilot period itself was kind of pie in the sky, like blue sky thinking. As Colin, as you said in your speech earlier, the problem is going to get worse before it gets better. And we discussed a lot at the start of the project that in terms of raw data about the prevalence of vicarious trauma, when there's this lack of knowledge about what it is at the start, if we had the data, first we'd probably see an increase in claims and an increase in the number of people who go, I think I'm experiencing vicarious trauma, just because of being aware of what it is. So in terms of the pilot period itself and the outcomes that we were expecting to see by the end of the pilot period and even over the next couple of years, we're not expecting to see that decrease just yet. So in terms of what I'm going to be talking about over the next couple of minutes, you'll note there isn't that decrease in vicarious trauma itself just yet, but I wanted to pick out and unpack a little bit just a couple of things. So first was really that the risk of vicarious trauma associated with a lot of this work, and this is the public service, was actually identified and acknowledged, I think, and not just for frontline workers, but also for, as Carmen said, administrative workers as well. So vicarious trauma as a concept originated in the sort of emergency services, and also in psychotherapy. So applying it to roles like, so mysterious. So applying it to things in the public service, while not incredibly new, we were not the first people to do that, I believe, but it is quite new in the scheme of things overall. And I'll talk a bit on the next slide about what that meant for some of the people that we worked with. There were also some successful controls in terms of the things that we piloted. They were based in part on the research literature that already existed, and also in part, and quite significantly, based on just talking to people at these sites and, what does the client need? Well, what do people think needs to be addressed in their workplace? People know what the causes of issues are in their own work. And a lot of this is giving them the chance to be heard, I think. And also that increase in discussion. So I will jump into that right now. So I guess a huge thing that came from the project's involvement was really that the risk was openly acknowledged. So we heard from a lot of staff, and it's similar, I think it really, really overlaps, and Carmen, you probably have so much to say about this as well, is that acknowledging the risk overlaps so much with the increase in discussion and therefore the decrease in stigma. So I've thrown up a couple quotes on there, and I might just give you a moment to read some of those. But in terms of acknowledging the risks, there was both this organizational sort of, not mandate, but when leadership come out to say, this is something that we really care about, this is something that we're going to look at preventing, that really does have an impact, I think. And then also in terms of how you apply that day to day, like it says up there, one of our pilot sites started, actually I think two or three, started including questions on vicarious trauma in their interviews for new candidates, both internal and external. So it wasn't scored. It wasn't the thing that would stop you from getting the job or not. But it was just something to throw in there, both to get people thinking about it, to say you will be exposed to things in this job. We acknowledge that. We're acknowledging that this risk exists, and we want to start thinking about prevention. And it's not, I'm about to bring up a quote that's not on there, but if you contrast this with what one of the focus group participants said at the start of the project, about what Carmen just said about the stigma and the silence around mental health and work-related mental health impacts in particular. So they said that mental health, and this was in circa 2019 or 2020, wasn't something that they felt could be openly discussed in their workplace without fear of repercussions. And there was this unspoken culture that if you speak up about something, you're a bit of a problem or a loudmouth or a troublemaker, and it stops people from bringing that up freely. That wasn't anything wrong with that site. I think that pilot site, I think that that's just, as Carmen said, what the prevailing attitude towards work-related mental health impacts has been. I can see a very emphatic nod in the crowd. And so I think one of the key things that the project did was sort of give pilot sites an impetus for that silence to be broken. And of course, some of the methods of controlling the hazards or lessening the risk of vicarious trauma were quite successful. And like I said, we're not going to see that decrease just yet. So we measured success in terms of participant satisfaction and how it matched up with the theoretical framework that we were working with. And so particularly in the case of things like reflective practice, I won't get into that, but there's an evidence base to indicate that it should lessen the risk of vicarious trauma if these controls continue, and particularly in conjunction with other methods. So the pilot ended in September of 2022, and we had some successful outcomes, but where do we go to from here? Over the past year or two, I think it's very fair to say that there has been a huge increase in acknowledgement of an interest in vicarious trauma from many, many different sectors and industries. And I might be so cheeky as to say that I hope that in part of that might be the work of the project, but I also think that this project and the research undertaken by ISCRR was just very incredibly well timed in terms of getting ahead of those risks. But in terms of, we're coming to a stage where people are looking for answers on how to prevent vicarious trauma in the workplace, and the research undertaken as part of this project helps answer some of those questions, I hope. One more consideration is the anticipated commencement of the amendment OHS regulations for psychological health. I won't speak too much about these, but to say that the draft form has indicated that exposure to traumatic content and therefore vicarious trauma will be quite an important risk in there. So in Victoria, there just is this upcoming and ongoing huge push to prevent both work-related mental health injuries in general and also vicarious trauma. And I think like even just in the time that I've been on the project, this is huge, because the amount of acknowledgement that there is now versus I started on the project in 2020, and the difference is phenomenal. So, and of course, there will continue to be further research and development and innovation in this field. So this year, we are continuing to work with the Departments of Justice and Community Safety and Family Fairness and Housing. And I know that ISCRR is going to, I believe, is going to continue working in the field of vicarious trauma as well, both with CPSU and beyond. So it is just overall really an incredible growth area in terms of research and innovation. And if you haven't heard of it before today or before a couple of years ago, there will probably be a lot that you will start to hear about it. Yes, thank you for listening. I think how are we going for time, Jimmy?
So I've only got time probably for one question. Just a reminder for everybody in the audience or listening online that if you do want to participate and answer questions, even if they're not covered today, please log on to Slido, use the hashtag IRIS, IRIS, and then you can post your questions there. You can look at the program as well. And also there will be an evaluation survey that you can click at the top menu to leave your feedback on based on today's session. Now, the question that came through, and this one I'll be directing to Carmen first because it just came through the online chat, that maybe try to keep response to about just 30 seconds. Just a quick response about, but it's a very loaded question. What would a vicarious trauma policy look like?
Thanks, Jimmy. 30 seconds. I think it would look like having a comprehensive framework of what vicarious trauma is, but then also a dedication or a commitment to prevention. And I think in one of our pilot sites, someone said to me one day, they kind of had this light bulb moment. They said, it's about not if you're impacted, but when. And a policy that acknowledges that and is built on that is really what a good vicarious trauma policy looks like. Is that all, Jimmy? You've gone.
Was there anything you want to add to that, Grace?
No, that was fantastic. Thank you, Carmen.